This presentation covers some benign ovarian pathology, which includes non-neoplastic ovarian cysts and stromal hyperplasia. Solitary follicular cysts or corpus luteum cysts are extremely common and occur when physiologic cysts become larger than 3 centimeters in diameter. They're usually an incidental finding in patients of reproductive age. When persistent, they may cause symptoms secondary to a pelvic mass, and occasional cases are associated with manifestations of excess estrogen production, such as precocious pseudopuberty in children, or irregular menses and/or endometrial hyperplasia in women of reproductive age. Follicular cysts or corpus luteal cysts may also rupture, leading to hemoperitoneum. These images show the morphologic hallmarks of a follicular cyst. Grossly, these are unilocular, or a single cyst. They're thin-walled and have a smooth external surface. They're larger than 3 cm but less than 8 cm. Microscopically, the cyst is lined by several layers of granulosa cells and luteinized theca cells, so they appear morphologically similar to physiologic cysts. These images show the morphologic hallmarks of a corpus luteum cyst. On cut surface, there's an orange-brown appearance with central hemorrhage. Again, the histology resembles a normal luteal cyst. What distinguishes it from being pathologic is merely the size. A corpus luteum cyst is distinguished from a follicular cyst by its undulating contour and marked luteinization, or this swollen eosinophilic appearance of the granulosa cells. Multiple follicular cysts are part of the spectrum of abnormalities seen in polycystic ovarian syndrome, or PCOS, characterized by hyperandrogenism of ovarian origin, resulting in virilization, infertility, obesity, and insulin resistance. This goes by the eponymic name of Stein-Leventhal syndrome. The etiology is unknown, but it's marked by dysregulation of enzymes involved in androgen biosynthesis, resulting in excessive androgen production, which is considered to be a central feature of this disorder. In addition, women with PCOS show insulin resistance and altered adipose tissue metabolism, which contributes to the development of both diabetes and obesity. There is abnormal gonadotropin release, low FSH and high LH, hyperandrogenemia, an elevated serum estrone level, and in some cases hyperinsulinemia. These findings suggest the pathophysiology involves abnormalities of the hypothalamic ovarian axis. PCOS is very common, affecting up to 10% of reproductive age women, and up to 10% of these women with PCOS show clinical manifestations. The clinical symptoms are related to hyperandrogenism and include anovulation, infertility, menstrual disturbances, obesity and insulin resistance. Hirsutism, acne, and male pattern baldness are seen in some patients. This image shows the typical bilateral ovarian enlargement, which you can assess by comparing the normal ovaries here in the center of the image, and contain numerous simple follicular cysts as well as expanded stroma. Microscopically, these have the same appearance as follicular cysts described earlier, except for the fact they're multiple. And in addition, there's usually expansion of the stroma. Stromal hyperplasia is characterized by a non-neoplastic proliferation of ovarian stromal cells, whereas stromal hyperthecosis is characterized by stromal cell luteinization in a background of stromal hyperplasia. Stromal hyperplasia and hyperthecosis are most common in the 6th to 7th decades, occurring in more than 1/3 of women in this age group. Many patients are asymptomatic, but androgen hypersecretion may be present, particularly in younger reproductive age women with stromal hyperthecosis. So there's some clinical overlap, especially in this younger age group, with PCOS. The only difference is that it's not accompanied by multiple follicular cysts. These patients are characteristically virilized, obese, hypertensive, and hyperinsulinemic. Some patients with hyperthecosis have estrogenic manifestations, such as endometrial hyperplasia or even well-differentiated carcinoma. Grossly, stromal hyperplasia and stromal hyperthecosis are typically bilateral and may be associated with normal-sized or more frequently enlarged ovaries, which have a diffuse or nodular, firm, white to yellow cut surface. In stromal hyperplasia, there's nodular and or diffuse bilateral cortical and medullary proliferation of mitotically inactive stromal cells, with ovoid nuclei and indistinct nucleoli, frequently more present in the medullary region. In stromal hyperthecosis, there's aggregates of luteinized cells, which have abundant eosinophilic or vacuolated cytoplasm and central round nuclei with small nucleoli, again typically present in a background of stromal hyperplasia. This image demonstrates stromal hyperplasia. You see both a nodular as well as diffuse hyperplastic proliferation of cellular stroma with a notable lack of cysts. This is typically bilateral and frequently found during menopause. This image shows stromal hyperthecosis. Again, there's a background of stromal hyperplasia, but there's nests of eosinophilic and vacuolated luteinized cells that are dispersed throughout the hyperplastic ovarian stroma. Since this was a little bit longer presentation, let me summarize what you've learned. There's follicular and luteal cysts. These are usually incidental, but may cause pelvic mass effects or be associated with excess estrogen production. These are unilocular, thin-walled cysts lined by several layers of granulosa cells and luteinized theca cells. A corpus luteum cyst is distinguished from a follicular cyst by its undulating contour and marked luteinization of the granulosa cells. Polycystic ovarian syndrome is a clinical pathologic syndrome characterized by features of hyperandrogenism, insulin resistance, obesity, and enlarged polycystic ovaries. The pathology microscopically is the same as follicular cysts. Finally, stromal hyperplasia and hyperthecosis is often asymptomatic, found in a little bit older age group compared to PCOS, but may show some clinical similarities to PCOS, including androgenic manifestations, obesity, hypertension, and glucose intolerance, as well as estrogenic manifestations. The ovaries may be bilaterally normal or enlarged. In stromal hyperplasia, there's oval to spindled cells with scant cytoplasm, while in hyperthecosis, there's a background of stromal hyperplasia with single cells or aggregates of rounded cells with abundant eosinophilic vacuolated cytoplasm. Thank you,